I first met Josh professionally right after I became dean in 2005, when he made an appointment to meet with me to tell me he was a candidate for the job of the health commissioner of Baltimore City, and I liked him immediately. I mean, I really didn't know him other than Mr. Yingveld Olsen, and so I decided to help him get that job by giving him a stress interview that day. But I did it because I cared, Josh. I cared. Okay, and he was a great commissioner, and he led an incredible number of innovative efforts, and was a great partner to the school. I mean, we did lots of things together, and having him in that job was just a wonderful experience for all of us, as it is now with Lena Wynn. So. And then before that, he worked with Congressman Henry Waxman. So from 2001 to 2005, he was minority professional staff and the health policy advisor for Congressman Henry Waxman, and that's the reason we were able to get Congressman Waxman here as a Centennial Scholar to our school. So he covered a whole variety of things, and it was a great training ground in public health, because whether it was healthcare or emergency preparedness or HIV or politics and science during the Bush administration, he did it all. So Josh graduated, and I always am, when I think about Josh and how accomplished he is, I'm always humbled by the fact that he has no formal training in public health. Right? He has lots of experience, but no formal training. He graduated summa cum laude from Harvard with an A.B. in social studies, and then while he was a medical student at Harvard, from August 91 to August 1992, he worked on public health projects in Guatemala and Costa Rica with a Frederick Sheldon Prize fellowship. And he did that to follow, of course, Yingveld and to be with her. He graduated from Harvard Medical School in 1996, and he did a residency in pediatric at the Boston Combined Residency Program at Boston Medical Center and Children's Hospital. And then he did a fellowship in general academic peds at BU School of Medicine in 2001. Right after we announced that Josh was going to come to the school, he was elected to the National Academy of Science, and the Institute of Medicine, and the National Academy of Public Administration. Now that was just, there was no causal association there, but I did take credit for it. And he also serves on the Board of Population Health and the Public Health Practice of the IOM, and on the editorial board of the Journal of the American Medical Association. He's won a lot of awards. I'm just going to list a few. They include the J.S. Trotman Memorial Award from the APHA, Public Official of the Year from Governing Magazine. So I don't know if you made the cover of that, and the Circle of Commendation Award from the Consumer Product Safety Commission. So he's been here for just over a year. It's hard to believe because he's done so much and had such an impact on our school. He came in January 2015 as the Associate Dean for Public Health Practice and Training and the first professor of the practice in the Department of Health Policy and Management. So I can go on and on. I have 2 more pages. I'm going to truncate it and just say that one of the things I appreciate most about Josh and his year here is the leadership he's shown and engaged Baltimore. And as you know, last April with the unrest and in Baltimore after Freddie Gray's death, I can't think of a better person to be the bridge between us and the community, both the neighborhoods around our school, but the city and state government. He's shown great leadership over the last year. So please join me in welcoming Josh Sharfstein and congratulating him on his appointment as the first professor of the practice.
Thank you so much for that very, very nice introduction and for bringing me to this school. This has been just really a fabulous year. I've had so much fun, and I have learned such a great deal. I thought that maybe I was going to not be the dean and go back in for a master's in epi, and then I changed my mind and I said I'd really like to do international health. Every time I go to one of the forums I change my mind, but then I sat in on an exam. I was like the practice person on one of the exams, and I decided I would back off because I didn't think I was going to be as good as some of the students at all. I'm going to be talking today about one of the areas that I'm working on, thinking more strategically about public health practice, looking to the future, and the opportunities of using healthcare data to reinvent public health practice, and I will explain what I mean by that. I'm going to be using a Prezi. I apologize if anyone gets motion sick. I occasionally go back and forth between PowerPoint and Prezi's. It was our then 9-year-old who came home and said he was sick of PowerPoint and could I get him a subscription to Prezi. And since then, occasionally use it. So what I'm going to be doing is first talk about what the data challenge is facing. Whoa, this is not the beginning. I'm already in trouble here. Already in trouble. Let's start. Oh no. All right, hold on. I'm going to try this again from the beginning. I don't want to start at the end with my thank yous. This is not good. Try it one more time. This is mine. There we go. Okay. All right. So I am going to be starting by talking about data challenges facing public health. Then I will be talking about how there is a new opportunity to help public health through electronic health data. I'll be going through some of the legal and ethical issues, talking about a couple practical considerations, giving an example of a really exciting project that the city is leading, and then finishing up. So to start, why is it important to ask about the data available to public health in practice? If you think about the public health response to Zika, and we've had some great lectures on and seminars on this, there is an enormous amount of public health effort to stay on top of Zika, and a lot of it is labor intensive. There's 24/7 reporting, the lab is working around the clock, there are frequent releases of case counts and data. Basically, Zika is getting managed day to day, not only in Latin America, but also the team here in Maryland has to be very on top of every breaking Zika update. But this is really the exception, not the rule. For the most part, with the you see Zika and you think, oh, public health is just on top of everything. That's actually very much not the case. For the most part, most of the data available to public health is not timely. Vital statistics is really the gold standard, an important gold standard, but it'll come out 6 to 12 months after the end of the year at best. The Behavioral Risk Factor Surveillance Survey, which is a really important survey. Right now, if you go on the web, you can get 2014 data at the county level, which is not great if you're looking at something that's relatively fast moving. The Medical Expenditure Panel is 2013. The National Survey of Drug Use and Health is 2014. County Health Rankings is a big data set that shows data at the county level. And some of it is quite old, merged over multiple years. When I was in the city, we would always get a call when that report came out and they'd say, Baltimore's not doing well in county health rankings. What's your answer? And I could always say, oh, that data's old. I told that story on Friday, and a guy raised his hand in the Q&A and said, I'm responsible for county health rankings. Gave me a little bit of a hard time, but it ended with, we know the data's old. America's Health Rankings, the big ranking system for states, also 2-3 years typically, at least in terms of the data. It's also infrequent, which is also important. It's not just that it's old, but it's just not collected frequently. Most vital statistics data is aggregated to annual. Sometimes you get monthly. Most healthcare survey data is collected once a year, and healthcare data from national data sets may be aggregated to monthly if you're you're lucky, but it's just a little dribble of data, and it's old and infrequent. And then the third issue is that it's not local. Counties can have millions of people in them. Zip codes can have more than 100,000 people in them. Census tracts can have thousands of people in them. So it's very hard if you're thinking about local communities, local neighborhoods, for health departments to really have a good sense of what's going on in any kind of meaningful, real-time way. And all those create different kinds of problems. So what problems do they create? First, it's difficult for public health departments to manage projects to outcomes. And this is from the National Performance Measurement Advisory Commission. I don't know if that's a very important commission or not, but I just pretty much typed in, how to improve performance. And you get 1,000 hits of, management. And you have to know whether what you're doing is working or having an impact. It's very hard to know that in public health. This commission said that Policymakers, executives, managers, and staff must have performance data to track and understand results. It allows the organization to learn from experience, replicate successful strategies, and improve on efforts that fail to meet expectations. I'm going to make a small aside, which is I've noticed since I've come over here that there's a funding pattern and a way of thinking where it's about evidence-based programs and implementing them. And I think one reason people implement evidence-based programs rather than implement strategies against results is that nobody has access to real-time data on results. So the best you can do is implement what you think is going to work. Whereas it would be better to be doing both, picking strategies that have evidence and actually seeing whether they're working. But it's very hard to do that. The second consequence is that it's difficult for public health departments to spot new trends. So I did interesting exercise this weekend. I pulled this graph from the recent CDC publication on overdose. And you see just the huge upswing in heroin-related overdose deaths. And that really started, if you go back, in mid-2010, and you can see it's really picking up in 2011, 2012. The first CDC alert was 2014 on heroin. And the most recent, and that was using data from 2012, right? So you can see they saw the problem in 2014 using data from 2012. And in 2015, they did this release that was as recent as 2013. Well, what's happening right now in heroin is very, very serious, and to be managing it like that with 2 years old data is a huge problem. It basically, the other example I was going to use is the fact that there was just a huge spike in fentanyl that it took a long time for people to get on top of. And the other types of consequences is it's without timely and local data on health, it makes the health department's job harder. It's not an easy job for the health department at baseline, right? You have the police department with a very important job. Everyone understands the firefighters are out battling fires. And, you know, public health has got to kind of fight for itself. We did, when I was the city health commissioner, the mayor would have community night, and we would all sit behind her. She would sit drinking a glass of water. Someone would ask a question, you know, why is there a vacant house on my block? And she'd turn around and ask she'd say, well, that's a question for the housing commissioner. And the whole time these meetings were going on, for the first 4 or 5 of them, I'd be getting text messages from the police commissioner. Sharfstein pitches another shutout. You know, there's just, nobody's thinking about health. They're thinking about what's affecting their neighborhood. It was only when we did reports about local life expectancy that we started getting questions. So if you don't have data, it's hard to get people to pay attention. The second thing, and I think that the relative political weakness of public health is in part due to its inability to speak about recent things compared to other, you know, do you know that there's this is what's happening with the jobless rate, or this is what's happening with crime. You can't really say what's happening with health now. You can say what happened 2 years ago. And finally, I think it undermines the credibility of public health when others are spotting key trends first. I can't tell you how many times that happened. Because if you really are getting data from a long time ago, surveys that happen once a year, and something new hits the street, you're reading about it in the paper. Why is that the case? Why should that be the case? So in that context, I think that there's a huge opportunity which we're just beginning to enter the world of in using electronic data. This is from the Office of the National Coordinator, just showing in hospitals how electronic health records are being adopted. So what is the concept? The concept that I want to talk about is about hospitals primarily, and I'll circle back at the end to non-hospital medical records. But health outcomes appear in hospitals, and population-based health outcomes. So if you're looking for everyone who had a heart attack, they're generally going to the hospital. You know, it's not quite the case everyone with hypertension showing up somewhere in the primary care system. But everyone with a major stroke should be showing up in a hospital. And so in theory, health departments could use those data that are accumulating in the clinical system for timely, frequent, and local data. So I'm going to go through a few examples. I apologize, this slide isn't quite right. But this is a chart that was put out by Georgia, a map in 2012. It used data from 2002 to 2006. But it was about hotspots of infant mortality. And it got me to think, what that text says, is that if we really wanted to look at birth outcomes on a more, and factors contributing to birth outcomes, what could we do on a more real-time basis? You could look at low birth weight babies and map their birth locations. You could look at people who are showing up late for prenatal care. You could see trends well in advance of waiting for the infant mortality to come out. This is a paper out of Cincinnati Children's Hospital on pneumonia. Because almost all the kids get admitted to Cincinnati Children's, they just use their own hospital's data. And it showed, what they did was they analyzed all the childhood pneumonia, they looked at the population rates, and they looked for hot spots and cold spots. And they found hot spots. And they were in areas that were pretty underserved for primary care and may have been under-vaccinated or had other problems getting attention before the kids got really sick. So they did this paper once and they published it. But in theory, if they had access to data, they could be intervening, or the public health department could be doing vaccination campaigns or working to expand people's understanding of the use of primary care, expanding primary care access directly, and then they could be watching to see whether the rates in those hotspots are going down. In Maryland, we have a fabulous health information exchange known as CRISP. And it aggregates pretty much in real time all the emergency department and hospital data. And the state uses that data to track certain metrics. And so makes that data available to those public health coalitions that Dean Clogg was talking about. This is one graph that shows the population-based rates of emergency department visits for dental problems. And you see that there are some hotspots in Baltimore. You also see a hotspot on the Eastern Shore. So, this is there. This could be looked at on a very regular basis. The health department could investigate and see what's going on, try something, and right away see whether it's having an impact. Why are people in that part of the Eastern Shore? Are there dentists there? What's going on? Is it just one person who got had 25 ER visits, or is there something else going on? Overdose is a huge issue. I showed you the data that CDC, looks like took a little while to figure out what was going on. You can get overdose data from hospitals right away. It's a code that hospitals put in. And you can look for different kinds of hotspots. You can look for individuals who've had multiple overdose admissions to see whether you can engage them in care. I asked the Maryland system 2 questions. I looked at the ER visits for overdose in 2012 and 2014 by zip code in Baltimore, and you can see this is with the same color scale. You can see that there was basically a 50%, almost a 50% increase in the population-based rate of ER visits in West Baltimore from 2012 to 2014. So there's been a massive increase over this period in overdoses in Baltimore. It's related to interesting and horrible things that are going on with heroin and fentanyl. But it is primarily on the west side, and you can see that from this, and you could use this data to really zero in and try to understand a little better. This map just sort of gives a bit of an example. I have a dream that you can look at healthcare data and really identify asthma factories in the community. What are the places that are generating asthma? Where do we think about where we could look for environmental problems, do pest control, do housing remediation, on the basis of kids constantly getting ER visits or asthma, rather than what we used to do, which was asthma education. How am I going to get a budget for increased asthma education nurses without knowing anything about the number of kids who have asthma, whether the problem's getting better or worse? But now we could say, we know 5 hotspots of asthma in this area of the city, and we want to fund an initiative to do code enforcement and housing remediation or whatever it is that we think is going to have an impact, and then we can see whether we're right. The difference between the previous scenario of let's have an asthma program, let's go around to doctors or do something, and we actually know what the problem is and we can design initiatives, is a night and day difference for public health. Just a few other examples. You could track hemoglobin A1C through lab values to see if there are clusters of at-risk individuals who live together to put in place, community-based diabetes management programs. You could look at the health outcomes of place-based policies and programs, partnering with law enforcement or transportation or housing. If I was talking to the Los Angeles Health Department, they were telling me about this big code enforcement initiative they were doing in this one area. And I said, if you thought about looking at health outcomes for what you're doing, nobody had the ability to do that. But if public health had access to these things, it could be a much better, more real-time partner to all the agencies that we all want to work with in order to address some of the underlying causes of poor health. And I think I have one more. And then you have air, water quality. It's strange. I find out that there is research that after certain types of rains, that they are, or in different climate, you have different health hazards, but there's very little real-time checking about that. And are things getting, there is some syndromic surveillance at a very high level. But if you were wondering about particular populations of patients, how are asthmatic patients doing with this kind of situation, the health department doesn't have the ability at this point to really be able to understand that in great detail. So I want to pause for a second and say I do understand, and I've learned an awful lot since in my time here, and I did take a few epi classes, so I'm not totally naive on the public health part, that it is very important to be rigorous in thinking about these things. That just because you can see it on a map doesn't make it so. So I think that the fact that we're doing a degree in spatial analysis and helping to train people in public health to think about spatial analysis is incredibly important as these tools become available. But I'd also say, just in terms of pausing, that most areas in the country don't have access to population-based healthcare information. And I will show some of these slides and talks, and people will tackle me afterwards from public health and say, what could I do to get this information? And I want to turn to that in a minute. So I do think that this is what I'm talking about is what might be possible, what is basically not being done anywhere at this point, and needs a lot more methodological rigor, is important for people to collaborate on methods, and is really not even a speck in the eye of most people in public health right now. Just a quick word on non-hospital data. It is definitely more complex to get at, especially if it's embedded in all these different electronic medical record systems. And it's less complete across a population. So, just because it's easier to say everybody with a certain condition is probably going to wind up in the hospital and feel more confident about that, rather than they're going to show up in an ENT clinic or some other type of clinic. That does not mean that it's not worthwhile. And obviously, if you're going to try to get population-based sense of how clinical practice is doing and prevention, it's essential to have a really good look at this kind of data. But I think what I'm talking about is something different. It's taking serious health outcomes and getting them more regularly so that you can actually see if what you're doing is working to affect the outcome that you care about. So how might a health department get started? And I just thought a little bit of practical discussion here might be helpful. So how many people have heard of ADT messages here? I know some people here are ringers in the topic, but so an ADT message, how many people here have heard of electronic medical records? Okay. ADT message is not an electronic medical record. If you go to the hospital and or you go to patient first and they ask you just at the very beginning, what's your name, what's your insurance, what's your birthday, couple basic questions, and then they go, okay, you can go back and sit down again, right? How many people have ever had that happen to them? Okay. That computer, that registration computer, is generating an ADT message. That is the message that opens up the electronic medical record system. It opens up the lab system. It opens up the other systems that a particular healthcare institution will have. And it's a very, very simple message. And you can copy that message and take a copy for a public health system or health information exchange. At the moment, it's being sent around the hospital. And hospitals can send ADTs without any impact to their workflow. It's just as soon as it gets generated, it's already making 6 copies, or it's going to 6 directions. You just send it to the 7th direction into a central repository. This is what an ADT looks like. It has all these weird numbers, it has the name, it has what kind of admission, is it emergency department, is it a hospital, is it nursing home, what the insurer is, and the address as the chief complaint. It doesn't know the diagnosis because they're still in, sitting there registering. So ADTs are very simple and powerful. They include unique identifiers that can be matched to a unique person. So that allows you to track an individual across different settings. It includes the home address. So in theory, that allows you to map it to any level of detail. And it includes the time, date, and facility information so you can track where patients are. And when you combine it with a master person identifier, which basically allows you to match, see in two data sets that you're talking about the same person, you can match ADT data with any other data that you have, as long as you have some basic identifiers. It doesn't have to even be sometimes exactly the same data in both sets. So if I were advising a health department to get going down this track of using healthcare data where they don't have any, I would say look at your hospital ADT data and see if you can get the hospitals to copy it and send it to you. And then the first thing that you could do would be to respond to high-risk clients. So a health department has doing these days a lot of case management for high-risk, for example, pregnancies, people with HIV, actually frank AIDS, multiple other discrete clinical populations. A ADT message, because it can get copied right at that moment of registration, can be matched against the patient list, and immediately the care manager can be notified. And this is being done in different locations for this purpose, where a public health case manager can find out in the middle of the night that their patient is in registration. And in Maryland, clinicians upload their patient panels, and the system sends about 800,000 of these real-time notifications a month. Step 2, you can actually look at a entire population that you're looking at once. So if you want to take the group of pregnant women getting home visiting, for example, and you want to see how they're doing with their hospital use, you could actually see that all up into the minute in real time, so you're not missing that they're going in and out of the hospital or having some problem you're not aware of. You could look at children in foster care as a group, if a health department that's responsible for a lot of people with disabilities, they could make sure that the care is good, that people aren't going back and forth to the emergency department without you knowing. You can take the ADTs and you can aggregate them at a geographic level because the address is in there, and you can actually look at admission rates and readmission rates just with the simple feed across populations. This is a map in Maryland that shows this, but you could do, and it shows it at the census tract level, but in theory you could do it at any level. And because you can see the same person, you can look at readmissions very easily and where readmissions tend to happen from, and you can track that over time. You can use them to evaluate whether initiatives are working if you're trying to reduce preventable admissions, for example, by having a panel of patients that you're reaching out to, or a geographic area. We're going to do an intervention in this area, and we're going to see what happens to the hospital utilization for everybody who lives in that area. You could very quickly see the impact for a whole range of different initiatives. And then finally, if you can get the discharge diagnosis, which you could also get in a lump file from the hospital, you could match it. And then you could be able to take all those different things and look at individual diagnoses. If you want to just turn on the lights for asthma, you'd see where your asthma is coming from. If you wanted to look at diabetes or falls or violence or overdose, you'd suddenly have specific maps at that level, skipping over essentially everything in the EMR and all the complexity of doing that. I think I mentioned this as already, that I do think that non-hospital data has a lot of potential, but to me the hospital data is a little bit easier for health departments to use because it's so accessible in either the diagnosis form or the ADT form for relatively few hospitals in an area. So, I'm talking about, a bit about the future, and a question that will always come up in any setting is, are we allowed to do this? Is if we're going to take healthcare data from people's medical records, use it for public health, is that allowed? And so I want to talk a little bit about legal and ethical issues. And I think when people think about public health getting access to medical data, it kind of in their mind, the general population might think it looks like this. This is a clip from The Office.
Does he have access to their medical records? I think one of the greatest things about modern America is the computerization of medical records. As a volunteer sheriff, I can look up anyone's psychiatric records or surgical histories. Yeast infections. There are a huge number of yeast infections in this county. Probably because we're downriver from that old bread factory.
I'm going to credit my son for that clip also. So part of the issue is you get into this and you have all these medical records available electronically. We're coming to potentially two different ways of thinking about accessing data. The clinical care framework is about the care team taking care of the patient, having access to data being made available for quality improvement and payment, and that's it. And it's generally a consent-based framework. You give consent, not necessarily for maybe payment and quality improvement, but you're signing it at the beginning, generally, that you're allowing your data to be used for that. Public health gets reportable diseases. So if you have a positive HIV test in Maryland, that is getting reported to the state health department whether you want it or not. And you may well have a public health worker come and try to help you make sure you get connected to the care you need and make sure that if you want help notifying partners that you can do that. So that's the case for a number of different conditions. So it is not based on a consent framework. It's based on the authority that a health department may have to promote and protect health. Public health is very different from research. So if you think about this, I'm not talking about taking the electronic medical records for the purpose of research, which is a very important purpose. But I'm talking about using it to design initiatives that improve health of the community. And this is important as you start to get into, a lot of people when they think about this, their first reaction is, well, you have to go to an IRB to use the data in this way. That's not actually right necessarily as a matter of law. The purpose of public health practice, this is the CDC's definition, is to identify and control a health problem or improve a public health program or service. And in HIPAA, there is the authority to disclose private information for public health activities that include public health investigations, public health interventions, and surveillance. On the other hand, there's research, which as we know is defined as a systematic investigation to develop or contribute, I think, to generalizable knowledge. But HIPAA requires an IRB to be involved there. So what I'm talking about is a framework that is under the public health framework, not the clinical care framework, and not the research framework. Where does HIT data fit? The laws that established a lot of the money that went into health data systems are very explicit that they expect them to be used to improve population health, reduce health disparities, and support public health agencies' authorized use and access to electronic health information. And in fact, Meaningful Use, the program that is kind of sunsetting but has been around as the basis for a lot of the payments for electronic medical records, envisions electronic reporting to public health registries. That's part of what was supposed to be designed into some of the software packages. So there's very much the concept that this is something that was understood about the use of electronic health data. That doesn't mean that you get to go to what Dwight was saying, that they get to everybody, the volunteer sheriff gets access to everyone's psychiatric records. These are what I think key principles should be. And I don't think, if you look around, we looked around, I had the great chance to work with my former chief counsel at the State Health Department, Joshua Auerbach, and he wrote a great memo for us on this. We couldn't find almost anything written about the use of the privacy and legal issues for using electronic health records for public health. So he helped me think about this quite a bit. And the principles that we came to were, number one, that it has to be justified, that there are obvious privacy issues, right? Just as there are with every use of data, whether it's for syphilis or lead poisoning or any other condition that's tracked by public health. So you have to have good public health practice. And that doesn't mean, that's not a fishing expedition. That's a plan to use the data to improve health. You should limit the use and the collection of identifiable health information to what is actually needed in terms of an organized plan. The use should be governed by legal agreements that require that data not be used for other purposes. The benefits to individuals should be clear. That I think it'd be a very difficult and I think probably wrong position for the health department to be using data in a way that didn't help the individuals whose data it was. There should be transparency of the data use and transparency about the impact on public health. So if we're doing a project to identify the places where asthma is being generated, which I told you was my dream, and there's a clear plan, everybody understands the health department's going to get the data, they're going to do outreach. Well, is it working? People deserve to know that too, not just that you're doing it. And I think that public input is valuable as this field kind of progresses. A couple quick practical considerations. In a lot of places, the hospitals, for example, won't share the data. And oftentimes, and sometimes it's quite explicit, that they won't share the data with anyone who is trying to keep patients out of the hospital. Okay, and I tell you some stories there, and that's part because the hospitals are paid by the bed. And where that's happened, it's very hard sometimes to get this kind of collaboration. But that is obviously a different lecture. That is changing. Where there's excessive competition in the market, maybe the word excessive is wrong, where there's a lot of competition in the market, hospitals tend not to want to share data. That was a paper by my medical school roommate that he wrote, showing that you see much more sharing of data and health information exchange in less competitive markets, which is, I think, unfortunate for public health. And then the last thing, which I think is really important, is lack of appreciation for tools of public health. So you're going to your public health department, you're approaching the medical system, and you're saying, I want to be able to look at your data so I can really help you reduce illness. And they're thinking like, what can you do to help me reduce illness? We're talking about our patients and our patients' data. We know what is best for them. And I have a whole slide set that I just try to show that public health thinks about things that clinical care doesn't think about. Public health has tools, and I'm speaking to maybe the choir here, but it's very poorly appreciated. People think of public health as really, really good case management. People think of social determinants of health oftentimes as getting people access to housing vouchers and food stamps. Public health thinks about it as what's going on in the community. Do we need to do an intervention there? Do we need to empower people inside a community to lead different kinds of change? All those things can be missed. And so if people don't appreciate that there are things that public health can bring to the table to solve problems, they're going to be less likely to share data. So I think that payment reform is extremely important for this kind of trend to move forward, because I think increasingly as hospitals have more incentive for better health outcomes from their patients financially, they'll want to support collaboration with public health around giving these data. I also think strategically, it's wrong, it's inadvisable for a health department to go to a health system and say, we want your data because we're the health department. Like, that is not going to be a winning strategy. Even, we want your data because we can do a lot of really interesting analyses with it. Not good enough. We want your data because we think that we have something to offer. Generally speaking, may not be successful. But if you say, we have had a doubling of overdose deaths, we have set a goal to address overdose deaths. We need to be able to help people who are coming to your ER for overdose and watch the map of overdose deaths. And this is about overdose in our community. That is a much more compelling case. I also think that there's no reason why a health department has to try to do this alone. If you're doing something on overdose and getting overdose data, you could do it with the groups and the allies you have in the medical and other communities, geographic neighborhoods who care about overdose. And so the case to a hospital to share certain data, for example, may be based on a realistic plan to actually move a serious public health indicator. So I'm going to conclude with an example of what I'm talking about, which is the use of healthcare data to think about public health very differently. To take a problem that typically would be a year over year, you get one update once a year, you're stuck with small evidence-based programs for discrete populations, and you're not able to manage to an overall public health outcome. And then we're going to change that into something that is much more of an urgent matter that the public health department can create progress on. And this is called Befriend, the Baltimore Falls Reduction Initiative, Engaging Neighborhoods and Data. And I'm really happy that there are some of the leaders of that initiative here, Darcy Phelan Emmerich, Mike Freed, Janae Khaldoun, and others from the health department. So what is Befriend? It is a public-private partnership based on using health data in support of a primary outcome. And the goal, as a health goal, is to reduce the rate of falls leading to an emergency department visit or hospital admission among older adults by 1/3 in 3 years. Now, this was one of 10 grants out of 400 submissions funded by the Robert Wood Johnson Foundation. Once it got funded, I said to the city, maybe we should have said 1/9 reduction in 9 years. Okay, because 1/3 of 3 years is pretty ambitious, but we might as well aim high, and in fact, the studies show that well more than that are probably preventable. So why falls? It's the leading cause of injury death for older adults. Falls are that one little line in that graph that are going up in age-adjusted death rates. Preliminary data for Baltimore shows that we have about 40% more serious falls among older adults than the national rate. Direct hospital charges, $35 million. As you may know, there are tons of other costs that come down the line after falls. There were 1,400 hospitalizations and 3,500 ER visits in a preliminary analysis for Baltimore City residents over age 65. And so the concept is to use the real-time data that we get from through the Health Information Exchange in Maryland, known as CRIS, match it with hospital billing data that would show the diagnoses to identify falls within a few weeks. We are working with CFIT, the Center for Population Health Information Technology, and Professor Karazi to develop the methodology to identify falls through CRISP. Use the master patient index that we have, the master person index in Maryland, to combine this with other data, including data from housing, where people live, whether people's home interventions, whether they're doing exercise programs, participating in senior centers. All that data can be matched in with whether or not patients are falling. Govern the data use with agreements developed in what we're in now, the planning phase, getting input from community organizations and others, and then having transparent reporting on how the initiative is going on the website. The idea is, previously when I was health secretary, I could find out falls in Baltimore once a year with a 6 to 9 month delay at the level of zip code. Okay, that's about as good as I could do. And now we want to take that to, a weekly mapping and other kinds of analysis that really allows for innovation. Putting evidence-based programs exactly where we think they'll have the biggest impact and seeing whether in fact they do. And so the idea is to get a cycle between the data, different actions, and results, and continual work. We have a initial governance structure. This is led by the city. There's a community engagement advisory board, which has a number of different community organizations already participating, and a data team led by Dr. Phelan Emmerich. And just to give you a little sense, well, what can you do? We're very much just starting. The grant was just awarded. But the idea is, if you have this mapping, there are several, I will say, evidence-based falls prevention exercise programs. You could put them in different locations and see whether they're helpful. There is evidence about different home interventions, so you could go into a community with a lot of falls and see what you could do. We're going to try to align existing resources. For example, the Housing Authority has their budget for different types of activities, both in the private market and in public housing. We're going to turn on the light and show them where people are falling, ideally, and they'll be able to direct other resources that they already have to maybe help. We're going to be thinking, people have thought about different things with city government, have a special system for 311 where people are seeing falls hazards in the community. They could report it a certain way or take a picture, and people could be on top of that. We're talking with the Center for Communications program here at the school, doing a falls prevention campaign, possibly focused around caregivers. with input from Jennifer Wolf and others, thinking about a problem that previously has been very using data that is completely locked away in the medical system, taking that data out, trying to learn from it, designing interventions that are community interventions, and seeing whether in fact they reduce falls. Ultimately, one of the ideas that actually the CFIT team has gotten funded for an InHealth award is to use all this data and generate a falls risk score that could be put back inside the medical records, could be mapped, and could be used for clinical types of interventions as well as evaluation of different interventions, because you could be immediately have the predicted falls in a particular geographic area. You do something and you see if you get that many falls or fewer. So this is pretty ambitious to start, and so I appreciate everybody who's working really hard on it. But to me, it's sort of a good example of the potential that you have, not just to think about healthcare data as for healthcare, but healthcare data for public health to get to really change what it does and have a big impact on outcomes. And I could say so far in the first month and a half, I think what I've noticed in these various meetings that we've had is that the promise of data brings people out of the woodwork. People say, like, wow, could I get data for my grant application about how many falls are in this area? If I'm going to do this particular initiative here, would I be able to get notifications about my patients if they wound up falling? There's so many questions people have. I think that we don't appreciate how hard it is to be working in an area really not having a good sense of outcomes. And this is the data that could create those outcomes. So I think that's pretty much what I had to say. I think it's going to be an interesting project. I want to thank all the people who've helped me think about this field. For DHMH, Dr. Herrera, Dr. Haran, at the Health Department, Dr. Wen, Dr. Phelan Emmerich, Mike Freed, and Dr. Caldoun, among others. At CRISP, which is the Maryland Health Information Exchange, David Horrocks and Scott Afzal. At Audacious Inquiry, which is a company that does some work with CRISP, and of which I'm an advisor, Chris Brandt and Rob Horst. And then Josh Auerbach, I mentioned, for legal guidance, and the people here at the school who've been incredibly helpful and supportive of my interests and time here, starting with Dean Clagg, my chair, Ellen McKenzie, the CFIT team, and certainly all the associate deans who are a great team to work with. So thank you very much. I look forward to your questions.
I didn't get motion.
You didn't get to see, okay.
So if anybody would like to ask a question, I'll ask you to use the mic so it's recorded for when we do the podcast. So let me ask a couple questions. So on your legal consultant, one of the criteria for using data in this way would be benefit to those whose data you use. Now, that's a very high bar. That's the requirement for enrolling a child in a study in Maryland, right? There has to be direct benefit to the individuals in the study. So say you're going to study asthma, maybe the prevalence is 5%. So that means 95% of the kids, if you're looking at asthma, don't get benefit.
I think maybe the point I was trying to make is that it can only help them. In other words, I get
prospect of harm.
Right. That you're offering something to them. So take the asthma example. If you were going to, I don't want to get too speculative, but if you were going to try to identify people who you thought might be doing something that would require some kind of enforcement. They were getting some medicine, they were selling it on the side, they were getting too many, something like that. That makes me nervous to do under a public health authority. I think that if it's a public health authority, it has to be, not that every single person whose data has to benefit, meaning, themselves, but at least they would stand to benefit, that there's not a risk that something could come back around and or at least the benefits well exceed the risks for them. Yeah.
Okay. Having gone through this with HIPAA and research at Hopkins, when we got HIPAA, we thought a lot about these issues. The other thing I wanted to ask you about, it's interesting you say the more competitive the environment, the less sharing of data. But doesn't the health information exchange obviate that concern? Once you can pool data at a central level, that gets away from the issue about sharing data.
Oh no, but the issue is that in markets where there the highest levels of competition between hospitals, they won't share data with the health information exchange. So the paper was, I think, whether people will be willing to have a health information exchange in their area. The markets that have hospitals very much on edge with each other, they're less likely to do that. They're more likely to try to build their own systems.
I see. Great. Thank you. So other comments or questions? No? Okay, you wowed them.
Oh, I think
Okay.
Professor Schoenrich.
Oh yeah, so Chris, could you get the microphone for Edith? Good to see you.
Among the many functions that our institution, the School of Public Health here has, is education. And here we are on a campus, with our medical school, with our School of Nursing, with our School of Public Health, and so on. Do you have some comments, perhaps, of how conveying the use of these kinds of data actually can improve the planning of health systems and the planning of even individual patients, so that medical students as well as students from public health area can benefit from kinds of data that they don't now realize exist or know how to use?
I think that's something that I personally want to work on. I think really understanding what the potential is, finding models where this is working, publicizing those models, developing projects with the city and others to get this to work. I think that's part of it. Right now, I think most of what I talked about is speculation. It's very frustrating to feel responsible for infant mortality and you're getting the rates so late. You're getting data so late. It's very frustrating. I mean, what's going on in overdose? Enormously frustrating in public health when you may not be able to get data rapidly about what's actually happening. And so I think that there's a huge potential. I think bringing the field along and is going to partly depend on developing the examples and the ground, kind of the basic fundamental foundation of being able to do this. And I'm interested in, working with people here. I've done some of that, but as well as writing about some of the policy and legal issues. But I think that where I would like to get would be courses that people can take that they can be inspired to be pioneers in what I think is going to be a new field.
Thank you. Great talk. How do you protect the personal identifiers in these data sets? Are they encrypted? And then a second question is, would you consider nesting randomized trials in your intervention?
Two great questions. So yes, you need, on the security side, there are a set of standards that include encryption, that assure, as well as how the data is kept, and there's often independent reviews of the security of different systems that are necessary to be, just like you have that for a clinical system, you have to have it as well, at least as strong for public health uses of data like this. Your second question was? Randomized trials. Yeah, well, the use of these data for research is, so there are two questions you're asking really there. One, the use of these data for research is another talk, very interesting, right? Because there's a lot of data available and there's a lot of insight you can gather. So I think research is very important and the framework there may be different, but it's very important. Take the Befriend initiative. We would like to be able to know whether the different falls interventions that are being put in place are actually having an impact. And just putting it in place and watching what happens to falls is a very simple and not rigorous way of answering that question. So one of the things that we'll have to confront as we're doing the planning phase is what's the best way to do interventions that are appropriate, and we can get good data about whether or not they're working. I was really inspired by maybe the Dean's lecture by Elizabeth Stewart a few weeks ago, because it just spoke to me directly, because it was basically how you can look at data in areas where there's not an intervention and data where there is an intervention and develop more rigorous conclusions about the outcome. And that's the kind of thinking I think we're going to have to put in place here. It may be possible either to do different ways of, I don't know whether we could get all the way to randomized without, but without more of a framework, the next level of a framework. But under even the current framework, I think we might be able to collect data in a certain way and look at it to really see whether we're having an impact, because evaluation has got to be part of good public health practice in this regard. I just want to tell people, I know that my mom's here, but you can feel free to ask me any questions. She'll be more critical than anyone when I get home.
Well, maybe we'd like to ask your mom some.
Yeah.
There was an example from Kenya of distributing smartphones throughout the country to report stockouts for essential drugs. And it led in a very, very quick time to pressure on the Ministry of Health to pay closer attention to budgeting and to distribution and so on. Do you see, with the improvement in electronic medical records and data in general, an opportunity in the future to actually budget into health department budgets the distribution of smartphones or other real-time monitoring devices to a group of volunteers that might then provide useful in real-time
Well, I think
data?
that, like the 2020 project that's here,
PMA 2020.
PMA 2020, is a fabulous example of how even in a pretty resource-poor location, you can get relatively real-time data to base policy on. And I think that there are multiple ways to go with this basic framework, and one of them is, are there faster ways to collect better data that maybe healthcare doesn't have? And I think that that's a great direction for public health also, in the United States as well as in other places. But I think that I'm really talking about some of the core outcomes that we care about in public health. That data is sitting there in the healthcare system, and it is pretty close to our reach. It's in reach in Maryland and a lot of other places, and it really could, there's sort of like the core work of public health to really move outcomes, and then there are different things that can be parts of strategies to get there. And so I'm supportive of both. I think that if you don't shift to having a better sense of your outcomes in a more real-time way, it's really hard to get the momentum to do the other things. I don't really believe that people don't care about public health. I've been in many meetings where you think that people don't care about public health. I don't think that's the case, though. I think it's that either they don't have the incentive to care about public health, which is important to think about, but often it's because the data you're putting on the table does not stand up to the data that they're getting on every other issue. And this is really a way to change that. So this is not just a data strategy. This is almost also just a pure strategy for public health to get increase its credibility and impact.
So I'll remind everybody that we have a party afterwards. We have a reception out by the Wall of Wonder, and so Josh will be out there to answer questions that his mother won't hear. I don't know what those questions are. You have some insight. Before we end, I want to recognize two people. One is Anthony So, who's in the back. Who Anthony, would you raise your hand? So many of you don't know Anthony. He just joined our faculty and in EHS, and he is the second professor of the practice. So we look forward to you speaking to us. And then PG Forrest, I see here. So PG, many of you do know, and he is the founding director of the Institute of Health and Social Policy, and he is unfortunately leaving us to go to the University of Calgary to be dean of the School of Public Policy there. So PG, we loved having you here. We were going to miss you a great deal. Good luck in your new position. Okay. And then we have some really good French. No, we don't, unfortunately. But we have some wine out there, and we can toast Josh and
Okay.
PG,
Well, join me in thanking PG.